All right, Protocol 41 is your newborn neonatal resuscitation protocol. And again, there is no real change in this protocol from how you would handle a neonatal resuscitation patient from your current protocol. Okay, Protocol 42 is our overdose poisoning toxic ingestion adult protocol. It covers beta blocker overdoses, calcium channel blocker overdoses, tricyclic antidepressant overdoses, organophosphate poisoning, and for cyanide and carbon monoxide, it asks us to exit to the appropriate protocol, Protocol 23, which is our carbon monoxide smoke inhalation protocol. Top right-hand corner, there's a note on naloxone for our advanced providers, and we're going to cover that in the next slide. Okay, so overdose poisoning, toxic ingestion for adults. Our advanced providers can administer up to 2 milligrams of naloxone or Narcan, IV, IO, IN, or IM. And just a reminder, Narcan is titrated to the effect of adequate oxygenation. So we do not give Narcan to restore consciousness. Okay, Protocol 43 is our overdose poisoning and toxic ingestion pediatric protocol. The only difference here is for our advanced providers, and it has to deal with the route of administration for naloxone. Okay, so here's that reminder on naloxone. Naloxone is titrated to the effect of adequate oxygenation and ventilation, not to restore consciousness. We are giving Narcan or naloxone to restore ventilations. Naloxone dose is 0.1 milligrams per kilogram, and the route is IN or IM only for the pediatric patient if the advanced provider was to give naloxone. Okay, Protocol 44 is our pulmonary edema CHF protocol, and it is broken down between mild, moderate, severe, and cardiogenic. We're going to go over this protocol. Okay, so for those patients that are presenting with a mild pulmonary edema or CHF, for our advanced providers, they're going to start treatment with nitroglycerin at 0.4 milligrams sublingual times 3 every 5 minutes, and nitro paste 1 inch. Of course, we want to maintain the systolic blood pressure of greater than 90 millimeters of mercury. For our moderate to severe presentation, which you will see in your patients with an elevated heart rate and elevated blood pressure, all provider levels will administer the nitroglycerin at 0.4 milligrams sublingual times 3 every 5 minutes, and nitro paste 1 inch. Obviously maintaining systolic blood pressure greater than 90 millimeters of mercury. Also, they will be administering continuous positive airway pressure, begin at 0 centimeters of H2O or PEEP, which is positive end expiratory pressure, and slowly titrate to achieve a positive pressure of 5 to 10 centimeters of H2O. Let's take a look at CPAP. There's a few contraindications when using continuous positive airway pressure. The first is respiratory or cardiac arrest. Patient unable to follow commands, patient unable to maintain airway independency, major trauma, suspicion of pneumothorax, vomiting or active GI bleed. And of course, we are going to talk extensively about CPAP in the skills portion of this training. Okay, Protocol 45, your respiratory distress adult protocol. This is broken down between whether or not the patient is wheezing or the patient has stridor upon your physical exam. All right, for our patients who have wheezing, all provider levels will be administering albuterol 2.5 milligrams in 3 mLs of normal saline times 3 as needed, as well as airway CPAP, continued positive airway pressure. Pulse oximetry and end-tidal CO2 should be monitored continuously if the initial saturation is less than or equal to 94%, or there's a decline in the patient's status. For our patients who present with stridor, once ALS has been done, our treatment consists of airway, continuous positive airway pressure, if indicated. All right, respiratory distress pediatric. And this is broken down between wheezing and stridor, and it's also broken down on the wheezing side even further, age 1 year or greater, and whether or not this is their first wheezing episode or this has happened before. Okay, so if the patient is wheezing and they are over 1 year old, all provider levels will be administering albuterol nebulized, 2.5 milligrams times 3 as needed. If there is no improvement, they will administer the EpiPen. Patients greater than 30 kilograms get the EpiPen, less than 30 kilograms, EpiPen Junior. and that is administered IM. If they are under 1 year old and this is their first wheezing episode, we will administer albuterol nebulized 2.5 milligrams, and you may repeat once as needed. If this is not their first wheezing episode, they have a history of this or asthma, administer albuterol nebulized 2.5 milligrams, and you can repeat up to 3 times as needed. Now for our patients with stridor, all provider levels are going straight to the EpiPen. Greater than 30 kilograms, EpiPen. Less than 30 kilograms, EpiPen Junior. Seizures, protocol 47. No real change here for the basic and advanced provider. A good assessment, particularly for the postictal and the actively seizing patient. We want to get a blood glucose analysis. Protocol 48, or stroke or TIA protocol. Again, blood glucose analysis is very important in the instance of stroke. And of course, a good assessment using the Cincinnati Pre-Hospital Stroke Scale. Protocol 49 is your tachycardia adult protocol, and at the EMT and advanced level, there is no specific treatment here, different from what your current protocols state. Protocol 50, tachycardia pediatric, and the same is true, no specific treatment changes from your current protocols. Protocol 51 is a ventricular assist device protocol, or a VAD protocol. The VAD, or the ventricular assist device, can either be a left or a right VAD. Some things we need to keep in mind here is if the patient has a VAD, when we do an assessment of the patient, we will auscultate the left sternal border to the upper abdominal quadrant, and if the VAD is working properly, you will hear a continuous humming sound. Also, usually when the pump is working, there is no palpable pulses, no measurable blood pressure, and no pulse oximetry reading. So, with that being said, if there is signs of obvious death, all treatment we do with a VAD patient, we are withholding resuscitation, withholding compressions. Okay? If the VAD is functioning properly, we answer yes. We want to then establish whether or not the patient is stable or not. If the patient is not stable, we need to look at other general medical problems. Do an appropriate assessment. Maybe it's possibly hypoglycemia. Maybe it's narcotic overdose. Maybe they're volume depleted. If they're volume depleted, our advanced providers are going to establish an IV and give rapid normal saline fluid boluses. When ALS gets on scene, we want to have EKG ready so they can determine whether or not there's an abnormal cardiac rhythm, and our ALS providers can treat appropriately. Also, is there an alarm? We want to treat for cardiogenic shock, change the controller if instructed. So is the pump connected to the controller connected to power? These do run off of battery power, however, they can be plugged in when the batteries are low. Urgent transport to a VAD-capable ED is the most important treatment we can do. So we want to always contact the VAD implant center. We want to allow the patient's trained companion to stay with the patient, and we want to transport all of the equipment that came with the VAD with the patient to the hospital. The VAD-capable EDs in our area is Inova Fairfax Hospital, MedStar Washington Hospital Center, University of Virginia Medical Center, and University of Maryland Medical Center. And within your protocol, there's a lot of information on a ventricular assist device. It's your responsibility. You need to become familiar with the troubleshooting procedures. These are going to become more common in our area.